Good evening, everyone, and welcome to Data and Perspectives, where our faculty will discuss the current and future management of diffuse large B-cell lymphoma. I'm Chris Flowers, Professor and Chair of the Department of Lymphoma and Myeloma here at MD Anderson in Houston, and I'll be moderating this meeting for you this evening. Here are our faculty here for our presentations who will be joining me. Dr. Laurie Sehn, Chair of the Tumor Lymphoma Group at the BC Cancer. Greg Nowakowski, Professor of Medicine and Oncology at the Mayo Clinic. So this program is CME accredited for one AMA PRA Category 1 credit and supported through educational grants from the companies that are shown here. In terms of disclosures, there are relevant conflicts of interest included in your pamphlets and listed on the slides here that follow. The planners and the content peer reviews from Medical Learning Institute and the accredited provider Research to Practice do not have any relevant conflicts of interest to disclose within eligible companies. And the conflicts of interest for each of the faculty are listed in your programs. So this program will contain discussions of non-approved agents and regimens. Please refer to the official prescribing information for each product for the approved indication. So now we're heading into the events for the evening. We're going to start out with Dr. Sehn discussing first-line therapy, and then I'll talk about the integration of novel agents in the care of patients with relapse disease, followed by Dr. Nowakowski, who will finish out discussing bispecific antibodies. So Dr. Sehn, I'll turn the podium over to you.
Great. Good evening, everybody. So I've been charged with talking about the frontline management of diffuse large B-cell lymphoma. And what I'll focus on a little bit is where we stand and where we think we'll be making progress in the future. So for those of us that treat diffuse large B-cell lymphoma, this is always a bit of a double-edged sword. We know that many patients can be cured with a historic standard of care, which is R-CHOP, but there is a subset of patients that's quite substantial that declare themselves to be treatment resistant, and most of those patients who relapse or have progressive disease will do so relatively early within the first 1 to 2 years. So the real challenge, I'd say, is how to overcome this resistance and push that curve up in the frontline setting. We've been talking about the heterogeneity of DLBCL for a long time now. So for more than 2 decades, we recognize that there are at least 2 subtypes of DLBCL that can be distinguished with gene expression profiling, which have been termed ABC and GCB subset. These are important because we recognize that there are different biological mechanisms that drive them. And if we move into the era of targeted therapy, it's possible that some of our drugs might be preferentially active in one versus the other. So it really has been the premise for some of the recent trials that have focused on individual subsets. But also, we know that this distinction is also prognostic, with the patients with the ABC subtype having a poor outcome. But this is evolving. So conceptually, although we think of the GCB subgroup as a more favorable subgroup, we recognize that when we do FISH testing and identify patients with a dual rearrangement in MYC and BCL2, these are largely within the GCB subset and is now pulled out as a separate entity, which we commonly refer to as double hit lymphoma. But recently, investigators at numerous institutions have identified that we can identify a porous subset within the GCB group that's not truly double hit, that has a biology that's similar to double hit lymphoma through gene expression profiling. Different names have been applied, but typically commonly referred to now as the dark zone signature DLBCL. And I think this is important to start recognizing because as we try to make progress, we'll probably need to focus on patients with the poorest biology. Because if we pull this group out of GCB, you'll see that their outcome is actually worse than even the ABC subgroup, which is shown on the red curve here in this diagram. Beyond gene expression profiling, there have been many genomic studies that have aimed to further classify DLBCL. So we know that the distinction doesn't end there. Through genomic studies, we've had several classifiers proposed that further divide patients into more discrete subsets. I say this is not quite ready for prime time yet, but moving forward, we should be capturing this information, and it is likely that we will need to pay attention to make progress. So there have been numerous randomized trials that have tried to introduce novel agents and improve outcomes beyond R-CHOP. But universally, these trials have been negative, with most of the introduction thus far has been on drugs trying to preferentially treat patients with ABC subtype of DLBCL. I'll just highlight a few things that I think we're interested. So although these trials were negative, I think we have learned some interesting lessons that we should take forward. So the bortezomib R-CHOP trial was initially presented as a negative trial. 5 years of follow-up. Interestingly, this trial has actually emerged to be a positive trial. But looking more closely at biological subsets treated within this trial, the big improvement seen is within the ABC subgroup, as one might expect. But intriguingly, pulling out this dark zone cohort, or in this study called the MHD cohort, essentially we saw that the biggest impact of the addition of bortezomib was in this subgroup. So do I think we're all going to be using bortezomib? Not likely. I think that the world has moved on beyond this, but again, I think food for thought that some of our previous trials, we may have been missing the message by focusing too broadly. Similarly, the Phoenix trial aimed to add a BTK inhibitor to the R-CHOP backbone. This trial across the board was negative, but when we looked at subsets based on age, we saw that younger patients seemed to benefit not only with an event-free survival benefit, with an overall survival benefit. Also examined retrospectively in terms of individual biological subsets, it was quite striking to see that there were several genomic subsets, namely the MCD cohort and the N1 cohort that fall within the ABC subtype, that actually had remarkable benefit with the addition of the BTK inhibitor. So I think the question of the activity of BTK inhibitors is still left open-ended. But despite these historic negative trials, we recently had a trial that did prove to be positive. So polatuzumab vedotin, which all of you are familiar with as an anti-CD79B drug conjugate, was tested in the POLARIX trial in a double-blinded randomized study where it was actually replacing vincristine and R-CHOP. So we have pola-R-CHOP head-to-head against R-CHOP. This was done in a broad cohort of patients with an IPI score of 2 or higher. And the endpoint, the primary endpoint, progression-free survival, was statistically significant and in favor of the pola-R-CHOP. So the hazard ratio was 0.73, and at 2 years, the incremental or absolute benefit was approximately 6.5% in favor of the pola-R-CHOP. Interestingly, though, when subgroup analyses were done, and I will sort of preface this by saying these were univariate analyses, there did seem to be preferential activity in some cohorts of patients, namely patients, for example, with an IPI 3 to 5. But interestingly, we also emerged a story where there seemed to be preferential activity in the ABC subgroup. This was presented last year at ASH meeting, not yet published, but when we looked more closely at the patients treated in the POLARIX trial, at the subgroups divided up by ABC and GCB on gene expression profiling, we did see that there seemed to be preferential activity within that ABC cohort, but also interestingly, within the group of patients with GCB DLBCL, also benefit in the dark zone signature patients. Across the board, other subgroups have also been looked at. Interestingly, when we looked at older patients treated on POLARIX, they seemed to, not only did they benefit and tolerate the treatment quite similarly, there actually perhaps was even a slightly preferential benefit seen in older patients in POLARIX. This is important because we know that older patients represent a challenging group. Some older patients are not able to tolerate the full intensity of R-CHOP, so many of us downgrade R-CHOP by giving dose-reduced versions. A popular downgraded version of R-CHOP is R-mini-CHOP, and there's an ongoing trial right now that is actively testing the addition of polatuzumab to R-mini-CHOP in elderly patients. This will be an interesting trial to watch the outcome of because it is targeting a very elderly patient group of patients, which are often hard to get on clinical trials. So patients had to be either 80 years of age or older, or between the age of 75 and 80 with frailty. We don't know the results of this trial yet, but some initial safety analyses have been shown at recent meetings, and across the board for the 140 patients that were treated, it appeared that the combination of our mini-CHOP with a POLA was relatively safe, although there was some increase in toxicities seen in this older population, namely with higher risk of gastrointestinal side effects as well as infection. So there are numerous trials ongoing right now that I think will change the playing field moving forward. These are just some of the ones that I think we're most excited about. Namely, we've got ongoing trials that are retesting BTK inhibitors with the next generation BTK inhibitors combined with R-CHOP. We have the first-line trial that will test tafasitamab lenalidomide with R-CHOP. ZUMA-23 will actually investigate the upfront incorporation of CAR T-cell therapy, but in the highest risk patients with an IPI score of 4 to 5. We're all excited about the bispecifics potentially moving forward, and there are several trials ongoing right now, combining them with either R-CHOP or POLA-R-CHP. And then, more exploratory, we've got response-adapted trials using ctDNA and even novel approaches where we're trying to eliminate chemotherapy. And I'll just end with food for thought, that I think where we'd all like to be going inevitably is biology-driven approaches. So there was one trial that really was proof of concept that came largely out of China called the Guidance 1 trial. This was a randomized phase 2 trial that divided patients based on genomic classification and treated them with novel agents added to R-CHOP based on what was thought to preferentially be active within that subset. And across the board, patients had not only improved progression-free survival, but overall survival. I know that the US Intergroup is looking at creating a similar type trial here in the US, and also we know that there now is Guidance 2 ongoing in China where they have taken this forward to a phase 3 concept. Thank you.
Great. Well, thanks so much, Laurie, for kicking things off. And next, we'll jump into our case presentations. The first is a case from a patient of mine who I actually saw probably not less than 5 miles from here at our inpatient service. So this was a woman who had previously been quite vigorous, a 49-year-old woman who was admitted with an epidural diffuse large B-cell lymphoma with a compression fracture, who at the time that she presented was quite limited and had an ECOG performance status of 3. She had an interventional radiology biopsy that showed evidence of activated B-cell like subtype of diffuse large B-cell lymphoma, and then had a PET scan that showed evidence of stage 4 disease with bone marrow involvement and also with some bony involvement. And an LDH that was about 3 times the upper limit of normal. Her LP was negative, and she was initiated on POLA-R-CHP. So, in general, Greg, how do you choose between polatuzumab vedotin R-CHP and R-CHOP as your first-line treatment for diffuse large B-cell lymphoma, and what are the factors that you use to make those decisions?
Chris, this is a great question. There are 2 approaches really to do that. One is to look at the initial inclusion criteria in the study, which would be IPI 2 and above. And this patient would meet the inclusion criteria for the initial study, which showed advantage in progression-free survival, and as Laurie showed, no difference in overall survival. But Laurie also showed that the benefit appears to be the most in ABC subtype of diffuse large B-cell lymphoma, And many groups, including our groups, is utilizing an approach that preferentially we use POLA chip approach for patients with non-GCB or ABC subtype of diffuse large B-cell lymphoma. Now, I'm a trialist purist, so normally I would just adhere to inclusion criteria in the original study. But in POLARIX, we didn't really see a difference in overall survival. So therefore, not risking that overinterpretation of the subset analysis, which Laurie pointed towards, which were limited in a statistical significance, would actually harm patients in terms of the overall survival. So some groups, including ours, tend to favor POLA-R-CHP specifically for ABC subtype of diffuse large B-cell lymphoma.
Great. And then, Laurie, you presented really nice data on the subgroups by molecular subtyping of diffuse large B-cell lymphoma. One, let's assume that you're not at BC Cancer, but out in a community practice somewhere in Canada or in the US. How do you think that subtyping works in those settings? And then at BC Cancer, how do you use subtyping to make decisions about frontline treatment in that setting?
Well, I think there's variability across centers. As you say, in academic centers, it might be easier to access some of this information, although I have no doubt that probably people will be moving toward expanding their use of molecular analysis. But right now we know that simple immunohistochemistry is a good approximation for cell of origin, and that's probably still what is most commonly used as opposed to gene expression profiling platforms or more complex genomic analyses. Being a research center, we try to capture genomic and molecular data on all of the patients. We recently have incorporated the use of a molecular classifier within our own patients. Right now, we're hoping to actually use that information moving forward. I've showed you the data on the dark zone signature GCB subtype, for example. We're talking about probably moving toward treating those patients differently, similar to what we do for double hit lymphoma, because we know that their biology is very comparable.
Great. And Greg, I think you have another case for us coming up.
Yes, so this is the case of the patient which I've seen recently. So it's a 19-year-old female who presented with a couple weeks history of anterior abdominal mass. The CT showed mass involving chest wall, but also liver lesions. And CT-guided biopsy was performed and showed diffuse large B-cell lymphoma GCB phenotype without MYC translocation and without double expression of MYC or BCL2. In a case like this, in young female, you always worry about primary mediastinal large B-cell lymphoma. We do not see here dominant mediastinal mass. Nevertheless, LYM3CX phenotyping was also done and showed that this would be unlikely to be primary mediastinal large B-cell lymphoma. PET scan showed multifocal anterior abdominal wall mass and the hepatic lesions, as you can see here. In addition, there were areas of lymphadenopathy. So this patient would have a stage 4 disease with extranodal involvement and elevated LDH, so IPI3. And this patient actually entered the study of R-CHOP plus golcadomide versus R-CHOP plus placebo, which is currently ongoing. And you can see the study schema here. The phase 1 results from the study, which led to the development of the study, will be actually updated. The updated results will be presented at this meeting by Dr. Weston.
So thanks, Greg. And so tell me a little bit about what your thoughts are about the use of golcadomide in the first line. First, tell the group a little bit about golcadomide and how it fits into the paradigm for treatment for diffuse large B-cell lymphoma.
Yes, so this is basically a Celebron modifier, which is next generation of lenalidomide, if you would, which inhibits Celebron signaling. Initial studies in combination with R-CHOP showed that combination was feasible and was associated with very high rate of complete metabolic responses and high MRD negativity rates. So because of those initial results, this combination now is taken to this free study which you had seen. What's interesting about this combination is that the golcadomide is given for days 1 through 7. So we initially designed it this way to optimize the synergy up front, but then allow neutrophil recovery on time. And in the feasibility study, which led to this randomized study, it showed that this was actually feasible in the majority of patients. And this is another example of how Project Optimus by FDA also informs now our doses design, because there were a couple of different doses evaluated in a small cohort of patients. So it's really optimized dose as much as we could moving forward with phase 3 design.
Great. Well, thanks, Greg. And maybe we'll take one more quick question from Laurie about other ongoing trials in first-line diffuse large B-cell lymphoma. You showed us some of those, like the trial that is utilizing molecular subtyping to be able to look at patients for particular subgroups. What are your thoughts about that approach or other approaches in the first line?
Mm-hmm. Yeah, so I mean, we do have, for example, the Escalade trial, which was specifically targeting a non-GCB subtype patient, but many of the other trials are actually agnostic of subtyping. I think that, it'll be interesting. We'll have a lot of data emerging. We might have competing results where, for the first time, we might have numerous trials that read out positive, and I think we'll have to be exploring ways to try and compare across trials, or maybe look at those subgroups a little bit more closely within the trials, even if they're not powered, to help sort of guide what we do. But I think it's an exciting time, but we really need to wait to see the data. And right now, I think we're still left with R-CHOP and Pola-R-CHP being the universal standards of care.
Great. Well, I completely agree with those comments. It is a very exciting time for first-line therapy in diffuse large B-cell lymphoma, and look forward to seeing the use of molecular subtyping. Let's move on now to the second line, and I'll give a talk first running through some of the therapies for relapsed and refractory diffuse large B-cell lymphoma, and then you'll hear more from Dr. Nowakowski about other selected specific therapies. So these are my disclosures. They relate to my work as a consultant for the development of trials in lymphomas, and then my contracted research as a result of my role as the division head for cancer medicine, where I oversee all of the research alliances for MD Anderson. So I think one of the things that has changed the paradigm for patients with diffuse large B-cell lymphoma in the relapse setting, particularly for those patients who relapse early after frontline therapy with R-CHOP or Pola-R-CHP, is the use of CAR T-cell therapy in the second line. And Laurie and others have nicely outlined the paradigm for how CAR T can be used early on for early relapsing patients. But I think it's important to note that not everyone would benefit from CAR T-cell therapy. And this just shows one example from one small trial looking at factors that might predict individuals who are unlikely to proceed well with CAR T-cell therapy, including having more than 2 extranodal sites of disease, having a high tumor metabolic volume, or having a high elevated LDH. And when more than one of those factors was present, you can see that the progression-free survival in this study was quite poor. There are now a series of selected therapies that have been approved in the relapse setting for diffuse large B-cell lymphoma, and I'll go through some of those, and Greg will go through others. The first of those combinations being the combination of polatuzumab, bendamustine, and rituximab, and then I'll talk about selinexor, tafasitamab, and loncastuximab tesirine. And this shows just in general, at a high level, the overall response rates and progression-free survival that were shown in the early trials. So first, turning to polatuzumab, you heard about polatuzumab in the first-line setting, but it was first approved in the relapsed and refractory setting from this trial that was led by Laurie, where polatuzumab was used in combination with bendamustine and rituximab in a randomized phase 2 trial, where you can see with that yellow curve, bendamustine, rituximab, that there was an overall survival advantage for giving the combination of polatuzumab, bendamustine, rituximab. I think one of the things that's been a critique of this trial is that bendamustine, rituximab is not considered to be used commonly, at least during the era when this trial was conducted. But if you look at large-scale data sets and populations around 2018, 2020, it is actually something that doctors had used in the community at that time, clearly showing an advantage to adding polatuzumab to that regimen. And you can see here with more follow-up that the randomized controlled trial held those benefits, with the Pola-BR group having a median progression-free survival of 9.2 months versus 3.7 months with the group that had BR, and an overall survival of 12 months versus 5 months for the group that got BR alone. And there was an extension cohort performed for polatuzumab BR with more than 100 patients that really essentially showed that the same results that we're seeing in the randomized study held in this extension trial with more patients. When you look at the safety summary that's associated with that, polatuzumab BR was associated with neutropenia in about 47% of patients, but grade 3-4 in about a third of individuals, and that resulted in infections in about 22% of individuals that were grade 3-4. Peripheral neuropathy is a cumulative toxicity associated with the MMAE, the microtubule inhibitor that's associated with polatuzumab vedotin, but that toxicity is cumulative and occurs typically after 6 cycles, and you can see that with the combination of Pola-BR, that occurred in about a third of individuals, but only 2% of individuals at grade 3-4. Turning next to tafasitamab and lenalidomide, this was a trial that involved 80 individuals with this CD19-directed therapy combined with lenalidomide, where you can see a median progression-free survival of 12 months in that patient population and a median overall survival that was not reached in this group, with the final 5-year efficacy analysis just reported this year with an overall response rate of 57% and a median progression-free survival of 11 months and overall survival of 33 months. When you look at the safety profile associated with this combination, it was predominantly associated with the combination of tafasitamab and lenalidomide, with neutropenia being quite common in that group, as were other cytopenias, anemia, and thrombocytopenia. But when patients completed their 12 cycles of therapy and went on to single-agent tafasitamab, you can see that the majority of those toxicities were owing to the combination rather than the single agent. Next, I'll turn to loncastuximab tesirine, another antibody drug conjugate, where this was given first for 2 cycles at 150 micrograms per kilogram, and then at lower dose, continuing to follow up of patients. And you can see here from the LOTUS-2 long-term survival results, the progression-free survival shown to be quite favorable for the group that were responders, as well as favorable overall survival seen in this set with the recent follow-up publication in Hematologica in 2024. When you look at the adverse events associated with this agent, the ones to be aware of is a relatively unique toxicity seen among these patients, which is increased GGT. You can also see a neutropenia, thrombocytopenia associated with this in about a third of individuals who receive loncastuximab tesirine. And then finally, I'll turn to the ECHELON-3 study design, with this study looking at patients with relapsed and refractory diffuse large B-cell lymphoma and randomizing patients to the combination of brentuximab vedotin combined with rituximab and lenalidomide versus placebo and rituximab lenalidomide for patients with relapsed and refractory diffuse large B-cell lymphoma who had at least 2 systemic lines of therapy and were ineligible or had previously received stem cell transplant or CAR T therapy. And when you look at the outcomes by group, you can see that the overall response rate for the group that received BV plus lenalidomide rituximab was 64%, with a CR rate of 40% versus 41% and 18% in the group that received lenalidomide and rituximab alone. In terms of the progression-free survival, it was quite modest in this trial, with progression-free survival of 4 months in the combination arm versus the group that of 2.6 months in the group that received lenalidomide and rituximab. And this just shows the overall survival curves for these patients, with the BB lenalidomide rituximab group having a median overall survival of 13.8 months. And you can see that many of these trials in this third or later line are hovering around that 12-month mark. In terms of adverse events that we're seeing in this trial, the group that received BV and lenalidomide rituximab had neuropathy in about a third of patients, but you can also see that neuropathy was quite common in the group that received lenalidomide and rituximab. And the rates of febrile neutropenia were quite similar, and the rates of grade 3 neutropenia were quite were 88% in the group that received BV plus their LENR versus 77% in the group that received LENR. So finally, we'll turn to some cases for the relapsed and refractory setting. And our first case is a case that Dr. Nowakowski will present.
Thank you, Chris. So this is a 76-year-old gentleman who was diagnosed with large cell lymphoma GCB phenotype in March of 2019. He was treated outside of Mayo Clinic at that time with R-CHOP and radiation therapy to mesenteric mass and achieved CR. In July of 2021, so late relapse, he developed recurrent disease and he was initiated on salvage chemotherapy with rice, but he tolerated very poorly and had a stable disease as a best response and was felt to be not a candidate for additional chemotherapy or transplant. He then came to Mayo Clinic and after consultation initiated on lenalidomide and tafasitamab. And he actually achieved CR with this combination after 12 cycles and then continued for 12 cycles of therapy and then on tafasitamab single agent. We follow up periodically and he was always asking, can I stop tafasitamab? Should I continue? He elected to continue. But in February of 2024, he developed a relapse and the biopsy actually showed large cell lymphoma and this time CD19 expression was negative. Regardless, he proceeded with CAR T-cell therapy with Lysocell, which targets also CD19, and achieved CR after this therapy and now remains in CR. So this shows you some of the issues of sequencing of CD19 therapy.
So let's go on to a couple of questions. So Laurie, can you tell us a little bit about your experience with some of these agents in the relapsed and refractory setting, and if tafasitamab lenalidomide is one that you've used, kind of what your experience is with the tolerability of that regimen?
Mm-hmm. You know, so I have to say that practicing in Canada is actually not funded where I am for diffuse large B-cell lymphoma. We actually have recently tested it for follicular lymphoma in clinical trials, so I have used it in patients. Just, you know, putting the data into context, I think that if I had it routinely available for DLBCL, I think it does offer a relatively tolerable treatment, although it is a little bit effortful for patients that need to come in and get the TAFA quite regularly. I think most notably, I'm not really sure who are the best patients to consider that treatment in. As you know, that trial initially excluded the primary refractory patients, and the data both through the trial itself and in real-world analysis suggests that the patients that do best are the patients with delayed relapse. So, you know, maybe this was the perfect patient to consider it in, and they actually did very well, but sort of fitting with the data, I'm not sure if I had a patient with a, you know, a much more aggressive behaving early relapsing disease that I would be eager to use it.
Yeah. Maybe, Laurie, before we go on to other comments about other agents in the relapse setting, Greg, do you want to say a little bit about this patient and how typical this is of patients that you've seen that receive tafasitamab lenalidomide and what your experience is with using that combination?
Yeah, I would agree with Laurie that probably the later relapsing patients do better with this combination. Although in the original trial, there were quite a few patients which were refractory to salvage therapy and did quite well on this combination. I think one factor which I always highlight with tafasitamab is that it takes two to tango. If you look at tafasitamab by itself, only a quarter of the patients were responding to the antibody alone. And it's really a combination with lenalidomide which makes it a very potent combination. And unfortunately, as it usually is, sometimes the antibody as infusion is easier to start, and then lenalidomide arrives sometimes much later. And sometimes there's this tendency not to start it with the first cycle, but start it with the second cycle because it arrives mid first cycle to the patient. And I would strongly encourage everybody to start it as soon as lenalidomide arrives, because you really need those two to see the best results with this combination.
And Laurie, going back to you, other comments about any of the other agents in the relapsed and refractory setting, how your experience with using those and how tolerable they are and how you sequence agents there?
Yeah, so I think it is a moving target. You know, in my setting, I have used a lot of POLA-BR for patients, or for patients going onto CAR T-cell therapy, POLA-R as a bridge. I think, you know, the new kid on the block is the bispecifics that are showing real promise in patients who have been refractory to many of these other therapies, including CAR T-cell therapy. So I think many of us expect that bispecifics will likely jump forward, and I know that we'll be looking at the recent STARGLO data, for example, that probably justifies moving those agents forward.
Okay. So we have an audience question that's come in, and maybe I'll throw that out to you, Greg. So when you see the loss of CD19 expression in diffuse large B-cell lymphoma in the relapse setting, how does that affect the likelihood of response to a CD19-directed therapy like one of the agents that we've discussed or CAR T?
Yeah, so it's actually not really clear. It appears that at least in the preclinical studies, when we may have a more CD19 than we actually need for those agents to work together. In fact, some of the data indicates that, for example, treatment early on with tafasitamab could lead to better expansion of CAR T cells and avoiding some of the apoptosis of CAR T cells from overactivation. For loncastuximab, the trial did require staining for CD19, but this was not required in other trials of those modalities, including treatment with tafasitamab. So I think we still have to learn more about the sequencing of those therapies from real-world data. Initially, there was a lot of skepticism that indeed with CD19 negative disease by immunohistochemistry, those treatments will work. But if you look at the level of expression by protein expression or flow cytometry, there's still some CD19 present, and the question is how many CD19 do you need to actually see the activity of CAR T cells? And the perception is maybe you don't need to necessarily highly express, see the higher expression of CD19, and you still may see activity like in this patient.
And Laurie, I think you have another case to present in the relapse setting?
Yes. So this is a patient that I saw in my own clinic, 75-year-old female, multiple comorbidities, presented with fatigue, night sweats, and as you can see on the right, very extensive disease above and below the diaphragm, lighting up on PET scan, and biopsy of a cervical node demonstrated that this was diffuse large B-cell lymphoma, ABC subtype. So she was treated initially with 6 cycles of dose-reduced R-CHOP, had difficulty with tolerance, had some dose delays, but did achieve a complete remission on PET-CT at the end of treatment, and actually stayed in remission for 20 months, but unfortunately then presented again with cervical nodes, PET-CT scan, and biopsy confirming a relapsed DLBCL. At that time, she was even older and was not considered a transplant candidate because of her comorbidities. CAR T-cell therapy in the second line was not yet available for her. And to be honest, I'm not sure. I would have called her a marginal candidate for CAR T-cell therapy as well. So she went on to get Pola-BR in my clinic for 6 cycles, achieved a CR, and actually remains in remission 2 years later.
Wow. Really interesting case. So let's go on to a few questions about this particular patient situation. Laurie, you presented this patient who got Pola-BR in the relapse setting, and earlier on you presented about the use of polatuzumab in the frontline setting. Would you ever think about rechallenging a patient with polatuzumab vedotin later in a treatment course for a patient who had received it up front?
Yeah, so, we really have no data that explores the reuse of polatuzumab in that way. So I think that I would fall to basic clinical practice that we all use. If a patient had failed a therapy early on and suggested refractoriness to that therapy, I wouldn't be eager to go back to it, of course. If they had had prolonged benefit from a combination therapy that included Pola, like Pola-R-CHP, I think it's fair game to re-challenge, but with something like Pola-BR. But I honestly would say I would be judging what my options are, and if there were other agents that the patient hadn't yet received, I would probably more likely be using those than jumping back to the same agent. But I think, we'll learn probably through real-world data eventually whether or not there's utility in that. But I certainly would do it if the patient hadn't proven to be refractory.
Very And I guess the other issue that comes up there is managing the toxicity in that setting and understanding kind of how long it's been and how much neuropathy that patient
Absolutely.
has
So for the case of polatuzumab, we know that the neuropathy is cumulative, and so that's why it has largely been sort of truncated at 6 cycles. But I think readministering in a delayed fashion with some time in between probably would be safe, but I would certainly be watching patients for toxicity and omitting it if that were a problem.
So let's go on to our third module and hear from Dr. Nowakowski about bispecific antibody therapy.
Thank you. So our next couple of minutes, I would like to review with you some of the data behind bispecific antibody therapies and what I call a bispecific or T-cell engager revolution. Those are my disclosures. So I think most of you are familiar how they work. They bring the effector T cells in the proximity of the tumor. So they have this bispecificity. Typically, CD3 is targeted on the T cells, and different antigens can be targeted on the surface of the cells. In the case of the currently approved bispecific antibodies, that's CD20. And you can see those antibodies, and I'm showing you here a couple of examples, including 2 approved, glofitamab and epcoritamab in this setting. They have a little bit different structures. And sky is the limit with those. Those are like Legos. You can basically add it on 1 arm, you can add it on 2 arms, you can make it really close to tumor cells. You can make it a pentamers, like in the example there. But you can also have antibodies which are tri-specific or even quad-specific, which are now in development. So this is the beginning of the era, which will, I believe, completely change the way we approach hematological malignancies and solid tumors as well. So let's look at some of the data behind 2 which are approved in relapsed refractory diffuse large B-cell lymphoma. So this is glofitamab, again, anti-CD20 and CD3 bispecific antibody. You can see here the design of the phase 2 trial, which led to the approval. So patients had to have at least 2 prior therapies, of which 1 had to be anti-CD20 antibody anthracycline. You can see dose escalation schema there to mitigate cytokine release, which happens during the T-cell activation. In the schema of glofitamab, obinutuzumab is used as the pretreatment, 1 dose pretreatment. And those are the data with now extended follow-up and through the expansion cohort. In the study, you can see a large number of patients, over 150. What's really encouraging that the overall response rate is high, it's over 50%. And the CR rate, so really deep responses, are seen in about 40% of the patients. You can also see that the responses are durable. Particularly patients who achieve CR have excellent durability of those responses. And this is in heavily pretreated population, including a third of the patients who are relapsing post-CAR T cells. Now, the second antibody, which I'd like to show the data on, is epcoritamab. You can see here dose escalation schema. It's a little bit different than with glofitamab, and there is no CD20 antibody given first. So it starts at the lower level and then escalates to a target dose. This is the data from initial study, which established a recommended phase 2 dose, and then went into those expansion cohorts listed here. And that's the clinical data from expansion cohorts. So again, very active treatment with overall response rates of 60% and 40% or 41% patients achieving CR. So high response rate and really deep responses. In this study as well, 40% of the patients, nearly 40% of the patients were relapsing post-CAR T cells. So those antibodies are effective in the patients relapsing post-cellular therapies. And you can see the progression-free survival among responders was very encouraging, including overall survival, which has been excellent here. Now, the study was done during the COVID pandemic, so there were some deaths associated with COVID. You can see here the data also with COVID adjustment on this study.
So hopefully the COVID pandemic is behind us, and now with vaccinations, those results would even look better. Now, what's really cool about those bispecific antibodies, I'm here showing you here example of epcoritamab, that they work across different subtypes of lymphoma. So you've heard about dark zone lymphomas from Dr. Sehn and ABC and GCB. The bottom line is the surface molecules appear to be working in all those molecular subtypes. You can also see that it's working in transformed lymphoma, primary refractory lymphoma, post-CAR T-cell relapses, as you've seen. So it is an example of the therapy which appears to be quite agnostic to molecular subtype of lymphoma or previous exposure to therapy or chemotherapy resistance. Having said so, it's a small cohort, and additional studies, particularly on molecular correlation, a molecular subtype correlation of the responses are clearly needed. Now, the major toxicity which you worry about is cytokine release syndrome, just like we would see with CAR T cells, because the mechanism of action is very similar. But you can see it's usually of low grade, and it's quite predictable in the course of escalation of the medication. This is the data for glofitamab, and this is epcoritamab. Again, it usually happens cycle 1, and quite predictable based on escalation. Now, all of these exciting results provides, it's nice to put in a background of activity of other agents in this setting. This is the presentation done a while ago now, which look at the comparison of chemotherapy. Not surprisingly, they're much better than chemotherapy with historical comparison, but also chemorefractory patients. But what's also interesting that now we are start comparing those results even to CAR T cells, and you can see that the early results are looking good, although extended follow-up with bispecifics will be really required to compare them to CAR T cells and see if the durability of the responses is as good as we see with CAR T cell products. Now, they are effective post-CAR T cells. Are they effective prior to CAR T cells as bridging? Well, yes, they are. This is a data from the study which used bridging with bispecific antibodies prior to CAR T cell use. And you can see there was a higher overall response rate in this study, and the CAR T cell efficacy appeared to be unaffected by use of bispecific earlier on. Now, probably the biggest advantage of bispecific antibodies, which makes it the most exciting, is that you can actually combine them. So this is an example of the study which combined it with polatuzumab vedotin. We've heard about this combination of glofitamab with polatuzumab with very encouraging response rate and durability of responses. And they could also be combined with chemotherapy. And this is the design of the recently presented study called SCARGLO, where glofitamab addition was to GEMOX was compared to GEMOX alone. The randomization was 2-to-1. You can see the study schema here. I will highlight that patients need to receive at least one line of prior therapy. So this trial was taking patients as a second line, which are not eligible for transplant or CAR T cells. The primary endpoint of this study was overall survival, and you can see that use of bispecific antibody, glofitamab, was associated with benefit in terms of the overall survival when added to GEMOX. And when you see those results with overall survival, we want to make sure that all the other results are consistent. And indeed, you see that addition of bispecific antibody resulted in a higher response rate and deeper responses, including higher CR rate, and better progression-free survival as well. So this better tumor control did result in the improvement in overall survival in this study. The subset analysis in this study is interesting. This is a very busy slide, but I would just draw your attention to look by region. The overall survival was not as evident in Europe or North America, but the number of patients from these regions were relatively small, limiting the power of this comparison. So, in conclusion, the CD3, CD20 bispecific antibodies work and work very well. I think we all agree. You've seen response rates of about 50 to 60% with really deep responses in 40% of the patients. And they work regardless of prior therapy or molecular subtype, which is very important. The toxicity profile is favorable, which allows multiple combinations of those, and as also sequencing of those with other agents. And addition of bispecific antibodies to some of the older regimens like GEMOX or now with more intensified chemotherapy backbones as well can actually revive those regimens. I was not thinking about using GEMOX more often in my practice, but now I do consider GEMOX combined with glofitamab in, for example, bridging patients to CAR T-cell therapy. And I think that's my last slide. Thank you.
Great. Well, thanks, Greg, for a great presentation on the bispecifics. So we will go on to faculty case presentations next, and Laurie's got a great case coming up. But before that, you got off the podium, but you're still in the hot seat, Greg. There was a question that came in about loncastuximab tesirine. So back to the prior discussion, can you just tell a little bit about kind of your use of that agent, how well it's tolerated, and the settings where you use it?
I frequently use it for patients relapsing post-cellular therapies, CAR T-cell therapy, provided the CD19 expression is preserved. It is generally well tolerated. You have to worry about fluid retention, but that's something which we can manage quite well. Unfortunately, post-CAR T-cell therapy patients are frequently cytopenic, so you have to look at for neutropenia and cytopenia as well. But patients can be usually supported quite well with the growth factor support as well. I did not use it as a bridging therapy myself, but I think this would be another agent. With now polatuzumab vedotin moving to frontline therapy more and more often, there is a clear need for additional bridging therapies, and that's additional agent which we potentially could consider in this setting. Again, the worry here is about the sequencing of two CD19 targeting agents, including the CAR T cells, and there are some ongoing studies which are trying to actually answer the question if this sequencing would affect the efficacy of CAR T cells.
So let's go next to a case from Laurie that's a really nice illustrative case of the ways that bispecifics are used commonly.
Yeah, so this was a 58-year-old gentleman who had no comorbidities, presented with abdominal discomfort, and lab showed an elevated LDH, and a PET-CT scan showed predominantly a large mass in the abdomen that was causing his pain, as well as disease above the diaphragm as well, and a core biopsy from his abdominal mass showed that he had diffuse large B-cell lymphoma, GCB subtype without a MYC rearrangement. So he was, again, treated at a time that predated polatuzumab, but got 6 cycles of R-CHOP and achieved a CR on PET-CT. He actually did well for 14 months, but then developed recurring abdominal pain, and PET-CT and biopsy confirmed the same recurrent DLBCL. As per standard of care, which I would argue is still the current standard of care, he was planned for salvage chemoimmunotherapy and autologous stem cell transplant, but unfortunately he progressed after 2 cycles of our basic salvage, which is RGDP. So we redirected him to a CAR T referral. He received 1 cycle of Pola-R as bridging and then went on to receive Axi-cel. He had a promising early response with CR on PET-CT after 3 months, but surveillance PET-CT done at 6 months unfortunately showed further progression. So this is a gentleman who, I would say I would be very challenged historically to find a good option for him that would likely give him prolonged disease control after CAR T. Fortunately, it's early days for access of bispecifics in my own practice, but he was able to receive glofitamab on a compassionate access program, completed 12 cycles, and has achieved a CR.
So, Greg, any thoughts about that particular patient case and the use of bispecific antibodies in that setting? How do you make decisions about which one to use and the timing?
So this, in terms of the choice of the antibody, I'll start on the choice of the antibody. It depends a lot on the experience at the center. We started our program with epcoritamab. We have IBA both antibodies. We tend to use more epcoritamab just historically how we developed the program. But if you look at the data regarding efficacy, they are quite similar. Some patients may prefer time-defined duration of therapy with glofitamab, which could be a factor. On the other hand, understanding that in relapsed refractory setting, we worry about
possibility of the relapse, most of my patients have no problem with continuation of epcoritamab. In terms of the choice of the therapy in the third line, this would be typical indication for relapse of post-CAR T cells or other therapies like stem cell transplant in this setting. I must say I started using it a little bit in the almost the second line. So, let's say a patient relapsing or progressing after ARCH with primary refractory disease, which we are trying to bridge to CAR T cells. And now based on those encouraging data that CAR T cells efficacy can be maintained after bispecific antibodies, we started using it in this setting as well, particularly if patient was previously exposed to polatuzumab vedotin, which we had used before quite extensively in the bridging strategies.
We'll go on to one more case that I'll present, and this is a patient from our practice who is a 56-year-old patient who actually originally started on treatment with an R-CHOP plus X clinical trial protocol that was a randomized controlled trial and tolerated therapy quite well, with the exception of having neutropenic fever that resolved with antibiotics, but experienced relapse after 18 months, and this was after the period of time when CAR T cells was approved for early relapsing patients, and received CAR T cell therapy, and now returns with a new lymph node biopsy proven to be relapsed diffuse large B-cell lymphoma with an ABC subtype, and here for initiation of next line of therapy. So, Laurie, how would you think through a patient like this and kind of the next lines of therapy that you would think about after failing CAR T therapy?
Mm-hmm. Yeah, so, we've talked a lot today about the numerous options that are now available for relapsed refractory DLBCL. I think, we still probably don't have great biomarkers to let us predict which option is going to work best in which patient. I think you've heard a lot of enthusiasm maybe about the bispecific antibodies. Probably, I'd say, because without direct comparison of all the different options that we have, probably in what we recognize from the two pivotal trials that we saw with epcoritamab and glofitamab, those are very high-risk patients, multiply treated, highly refractory, and the results were comparable in both those studies. And I think what was most exciting about them is, although it's too early to say there's a plateau on those curves, and those agents are definitely curative, there's certainly patients that are out now, well beyond 3 years and sustaining complete remission. So when I see a patient, I always ask myself, do I have anything left to offer this patient that might have curative potential? And I think although there's always that plateau and all of the options that we talked about, some patients do really well. We just don't have a great way of picking out which patient is going to be that patient on the tail of the curve. But, I guess, across all the options, I would be probably moving to a bispecific antibody for that type of patient because, it probably offers the highest likelihood of having a durable control.
Yeah, I completely agree, and that's in fact what that patient received. Greg, for a patient who's not tolerating your first choice of bispecific antibody, would you think about switching to a different bispecific antibody?
That's an interesting question. I must say I did not encounter this situation. Usually you can mitigate the toxicity. I don't know if there's much evidence that switching would result, I guess it depends on the toxicity, of cytokine release syndrome, or why would they be not tolerating bispecific antibody. But I don't know if there's much evidence that switching from one or the other would have a different outcome.
And maybe just in the last minute, thoughts about sequencing bispecifics and CAR T cells for patients on the third line of therapy. Maybe first Greg and then Laurie.
That's a great question. I think with the activity which we see with bispecific being so encouraging, and the fact that you can actually use bispecifics prior to CAR T cells, and then you can build those new combinations by adding additional agents and hopefully extend the response rates and durability of these responses, it's going to be more and more relevant. Right now, we still follow the evidence. So in the second line, you get CAR T cells, and bispecifics will be reserved to post-CAR T cell relapses in the patients who are candidates for CAR T cell therapy. But I would not be surprised if this would change in the future.
Laurie?
Yeah, I think that, as I said, I usually ask myself, what can I give the patient that I think is going to offer them still a chance of cure. And with CAR T being developed first and longer follow-up, we're quite comfortable to say that is a curative potential therapy. I think we can't yet say that for bispecific. So in a scenario where the choice is between CAR T-cell therapy and a bispecific, and I think the patient can tolerate CAR T-cell therapy, I would probably preferentially go to CAR T-cell therapy. But it is rapidly moving. So you mentioned, what would I do third line? Well, we know that CAR T has moved forward for many patients to second line, but there are trials that are ongoing testing bispecifics, second line, and now even first line. So as that data evolves and real world evidence comes up of sequencing them perhaps in alternative ways, I think we may change our mind over time. But right now, the way the data stands, I guess I would be moving to a CAR T first in a scenario where I was considering those two options, as long as I thought the patient could tolerate it.
I completely agree with you that the data are moving really quite rapidly. You and I were talking earlier that we presented in a forum like this last year, and this is completely different from what we discussed in the last year. The data are moving so quickly. So I really would like to thank both of you as my panelists, and please give them a big round of applause. And thank all of you for joining us in this session on Data and Perspectives as clinical investigators discuss our current and future management of diffuse large B-cell lymphoma. We hope those of you who wish to review this again, join us online to review the recorded version that will be up and posted after this symposium completes in a few weeks. So thank you all for attending today, and enjoy the rest of the meeting.